to Dr. Professor Meenakshi Dhar, who is Professor of Medicine and Head of Department of Geriatric Medicine at All India Institute of Medical Sciences, Rishikesh. She is, besides MD Microbiology, MD Medicine, she is PGT Geriatric Medicine. After working in Department of Medicine for 20 years, she started the Department of Geriatric Medicine in Rishikesh. She is also involved in incorporating geriatric medicine in the curriculum for the undergraduates.
For giving me this opportunity to talk about this subject, which really it's really near close to my heart. For giving me this opportunity to talk about this subject, which it's really near close to my heart. Wait. What has happened to it? Slides are not moving. Okay, now they are. Fine, thank you for giving me this opportunity. Am I audible?
Yes.
So are my slides also visible, I suppose? So thanks for giving this opportunity to talk on the subject of adult vaccination, which is really an underutilized opportunity. And as the eminent speakers before me spoke about it, that this needs to be tapped very well so that we, give a healthy aging, healthy life to our older population. And I will not talk about this slide because Dr. Vinod Kumar has already explained this slide that as we age, there is waning of our immunity, and so we need to boost it up with the vaccines. All of us know that what is healthy aging and what are the eminent things which we require for healthy aging. We know that for healthy aging, we need to eat well, we need to do physical activity, we need to do the smoking cessation, screening for health conditions, and keeping a good hygiene. Apart from that, vaccination, like other these external influences, are all under our control, and if we take care of this part of preventable health modality, it's really going to make a lot of difference in healthy aging and preventing the much of a comorbidity among our older population. The studies have been, there has been a lot of studies in the Western countries actually, but the data is from the US. It shows that 99.5% of the adults who are more than 50 years of age are infected with varicella zoster infection during their lifetime, and they are at a risk of developing this shingles. We know that it starts with the primary infection, that is chickenpox in the childhood, which just manifests in the form of skin lesions. But once this goes away, this virus remains dormant in the dorsal root ganglion, and it remains there dormant throughout the life till the time we have a good immune system. But once, as we age, the immunity wanes off, and this dormant virus gets activated and manifests in the form of reactivation of this varicella in the form of herpes zoster infection. And we know that it manifests as a unilateral distribution in the different dermatomes, and most of the times it is the thoracic dermatome which is commonly affected. But what is more dreaded is when it infects the ophthalmic division of the trigeminal nerve, because then it can lead to blindness and increasing the more of a comorbidity burden in an elderly person. If you look at this slide, it shows that varicella primary infection induces when a person has this varicella infection in their childhood, it induces some varicella zoster specific cellular immunity. And this immunity is maintained, or it is on a higher side, or keeps the antibody concentration in the body on the higher side during the lifetime course of a person, because they may have recurrent subclinical infections, so that the immunity remains there. But once a person starts aging, or if there is any other comorbidity, if there is any other immunosuppressive state, this cell-mediated immunity reduces, and it predisposes the person to reactivation of this dormant virus, this zoster virus, and resulting in the varicella zoster infection, which is called shingles. So if we talk about the epidemiology, overall the global data suggests that the worldwide incidence of herpes zoster infection is 3 per thousand to 5 per thousand person years, and risk of developing post-herpetic neuralgia in patients who suffer from herpes zoster infection is around 5 to 30%, and even the recurrence rate of herpes zoster is around 1 to 6%. Talking about Indian data, even though the much of Indian data is not available as such, but whatever studies I could find is that the incidence of herpes zoster infection in people more than 50 years of age ranges between 15 to 81%. So there's a wide range because of the different variety of studies which I have come across, and the risk of post-herpetic neuralgia is around 10 to 54%. And this infection, or this incidence of infection and the post-herpetic neuralgia increases with the increase in the comorbidities and increase in the age of a person. Say that the risk of infection is more in immunocompromised patient, but it has been seen that the people who are even immunocompetent, they also have a high risk of having this herpes zoster infection, and the recurrence rate or risk of recurrent infection is also increased to about 5 to 10% in people who are even immunocompetent. The shingles or this herpes zoster infection is not just the infection of the skin, or it doesn't manifest in the form of a rash, but it has been seen in studies that it impacts quality of life in a very big way, as Dr. Vinod Kumar also said, that there is a large impact on the quality of sleep, the enjoyment of the life, and the general activities of the people drastically come down because of this shingles infection or herpes zoster infection, and because of this, the complication, that post-herpetic neuralgia problem. So they reduce the quality of a life of a person to a great level. And not only reducing the quality of life, it has been seen that the risk of complications which are associated with herpes zoster infection are quite high in people who are more than 50 years of age. Then the complications may be in the form of encephalitis, aseptic meningitis, or patient can have even keratitis, as I said, loss of vision. And it has been seen that this herpes zoster infection has been associated with increase in the risk of stroke, TIAs, and even the myocardial infarction in people who suffer from this infection. As Dr. Vinod Kumar sir also said, that it is not that we are preventing the infection, it is that we are preventing the non-communicable diseases as well if we are taking care of this herpes zoster infection. We know that if a person suffers from herpes zoster infection, there are some treatment modalities which are available. In the first week, we treat them with antiviral drugs. We give them the analgesics or anti-inflammatory to reduce the post-herpetic neuralgia. But studies have shown that this was a study which was done in around 350-400 patients who were suffering from post-herpetic neuralgia. And in that study, it was seen that only 14% of the people were satisfied with the treatment for post-herpetic neuralgia. That means 86% of population or the people were not getting effective treatment of this post-herpetic herpetic neuralgia problem. And as it is said that the infection, the infection with herpes zoster does not increases the risk of utilization, or increases the it is not cost effective, I should say. It increases the chances of more hospitalization, increases the OPD visits, it increases the chances of polypharmacy in an elderly person, which is another geriatric giant in older people. And there's a 25% increase in polypharmacy in the patients who develop this herpes zoster infection. And it has been seen in various studies that it increases the hospital stays by 21%. So COVID has affected every aspect of our life. So it has been seen during COVID time also that those people who were infected with COVID disease, they had a 15% increased risk of developing this herpes zoster infection. And those patients who were hospitalized because of the COVID infection, they had 21% increase in chance of herpes zoster infection. It is because it has been seen that developing herpes zoster infection may trigger the reactivation of latent herpes varicella zoster virus. The corticosteroids have also been implicated in increasing the chances of herpes zoster, and the risk of herpes zoster was highest in the first month after single prescription of steroid, and after discontinuing of the steroid for 3 months, then the risk of herpes zoster was found to be equal to those who had never used the steroids. And the risk has been seen to be increased with the increasing cumulative doses of steroids as well. Even those who are using the inhalational corticosteroids, the risk of herpes zoster has also been shown to be higher in those people. That is why it is mandatory for patients who are suffering from COPD, because they are taking these inhaler steroids. They should be definitely vaccinated against this herpes zoster. There have been large experimental observer blind placebo controlled randomized controlled trials which have been done in the in US and UK. They have done two studies were done, two parallel studies were done in patients above 50 years and above 70 years for checking the efficacy of this Shingrix vaccine on adult population. And what they found is that the Shingrix, it gives an around 99% efficacy against the development of shingles in patients who are above 50 years of age. Not only that, it is preventing against the post-herpetic neuralgia as well, and also decreasing the chances of other complications which are associated with a herpes zoster infection. So this was a 3-year follow-up period which they see. After that, a 10-year follow-up was also studied in these cases, and they have shown that the efficacy, 89% efficacy is still retained with this shingles vaccine, I mean, after the 10 years of the vaccination period. And after, during the, as one ma'am is going to talk about the safety of this vaccine, they observed the adverse reaction which were associated with vaccines, and they were quite tolerable. They saw that the simple local reactions, even if they occurred in the form of pain, redness, or swelling, it retained only for 3 or less days. And even the systemic side effects like fatigue, fever, or GI upsets, they remained there only for 2 days or less. So they concluded that it is quite a safer vaccine. And regarding the distribution of this Shingrix vaccine, it has been approved by 50 countries, and in India it is also available. And in India we recommend usually the 2 doses of Shingrix vaccine for the prevention of herpes zoster as well as for prevention of post-herpetic neuralgia in people above 50 years and 50 years of age. CDC recommends all the adults above 50 years may be given this herpes recombinant vaccine of herpes for herpes zoster, irrespective whether they have received the varicella vaccine in their childhood or not. And those people who are above 50 years with special conditions like rheumatoid arthritis, diabetes, or chronic pulmonary disease, they should receive this recombinant zoster vaccine should be given to them, especially those people who are suffering from asthma, because they are on long-term steroid inhalers. Even the various societies are recommending the use of zoster vaccine, including the societies from India, RSSDI, especially in people who are with diabetes, and other societies. Even API has come with the latest recommendations for adult vaccination, and they have included herpes zoster for people above 50 years with special conditions. It is recommended for them also. The other conditions where we should use this herpes vaccination, zoster vaccination, is people who are or with rheumatoid arthritis, people with psoriatic arthritis, multiple sclerosis, and other musculoskeletal diseases which are autoimmune related. In cancer patients, people who are undergoing solid organ transplant, including the renal transplants, people with HIV, and with multiple myeloma. And regarding the schedule of vaccination, it is, as I said, it's given in 2 doses, and primary vaccination schedule consists of initial dose followed by the second dose 2 months later, but it can be taken within 6 months of the first dose also. That flexibility is there. And it is usually supplied in 2 doses. One is the vaccine, antigen, and another is the adjuvant. So when we are reconstituting after reconstitution, it has to be used within 6 hours of reconstitution, and it should be refrigerated, but it should not be kept in the freezer. That is very important. Now the questions are being asked that when we are also recommending other vaccines. So people have this query whether what should be timing of the vaccine, whether it can be taken with other vaccines as well. So it is said that recombinant zoster vaccine can be co-administered with the following vaccines, but it should be taken at a different site. Influenza, pneumococcal, Tdap, all of them can be given, but at a different site. And there are no safety issues have been observed by giving them at the same time. So in summary, we can say that 1 in 3 people will develop shingles in their lifetime, especially those who have had an chickenpox in their childhood. And the herpes zoster infection impacts the quality of life to a greater extent. And studies have shown that vaccines have 90% efficacy across all age groups, especially people who are above 50 years of age. And there is a sustained response of the vaccine efficacy, sustained vaccine efficacy remain around 89% is there even after 10 years of vaccination. And it has been fully established that it is quite safe vaccine to be taken for elderly people who are above 50 years of age. Now coming to the another vaccine, which Tdap, which I was supposed to talk about. So before that, as Sir also said, that even though the incidence of tetanus has reduced drastically throughout the world because of this childhood immunization program, as well as the immunization of the pregnant females. And there was a systemic analysis which was done for the global burden of a disease study in 2019. And there they have shown that the disease burden of tetanus has decreased significantly worldwide from 1990 to 2019. Neonatal tetanus is a serious concern still in the low socio-demographic index areas like India. As I said, 40% contribution is from the Indian subcontinent, whereas elderly tetanus is more of a problem in the high socio-demographic income areas. So if we want to really contain tetanus, we have to address all the age groups. Addressing only one age group will not solve the problem. So we have to address all age groups and try to vaccinate people across the ages. Regarding the diphtheria burden, even though because I could not find much articles or latest articles on diphtheria, whatever I could find was last was 2016. So even talking about diphtheria, it has drastically reduced, but still India contributes to the 40% of the total global burden of diphtheria. 40% contribution is from India. And there have been, I found a few studies where they have studied the prevalence of diphtheria among children, in neonates, children, and young adults. So there were some studies which have shown that 7-8 studies were there which had adults or adolescents which were more than 10 years of age. They were having this diphtheria infection. And then the studies were also done in regarding the protection. The serological studies were done where they tried to find out what is the protection of people and what is the antibody status of the patient against the diphtheria infection. So they found that 54% of the adults are devoid of any protection against this diphtheria. So that makes it more imperative to vaccinate these adult population against diphtheria. Then coming to the pertussis, there's a global pertussis initiative expert committee is there, which looks after these programs, which gives consensus statements on prevention and treatment for pertussis. And they have seen that they have shown, or they have found out that because of the antigenic drift of the bacteria, because of the antibiotic resistances which is coming up, and because of the waning of the immunity, but the scenario of pertussis is changing in India, and now more of an acellular bacteria are coming up in a big way. So because of that, the vaccination has to be done against those strains, and because the people who were vaccinated initially, now they are exposed to another variety of an organism, so they need to be revaccinated to boost up their immunity. And this is what I was saying, because of the waning immunity, so we need to go for an acellular vaccine against the pertussis as well. That is why the single dose of Tdap should be replaced, and instead of we give the single dose of Td only. And it is recommended that the interval between the last dose of tetanus toxoid should be 10 years. Like if a person has taken tetanus toxoid, then within the 10 years, he should receive the vaccine for Tdap. He should be vaccinated against Tdap. Who all should be vaccinated? The parents, the grandparents, the children, or the child care providers, because sometimes the child becomes a reservoir, or he's vaccinated, so he's protected, but the child care provider becomes a reservoir. The child can again get reinfected with the this bacteria or the virus, whatever is there. And the healthcare workers, they should be vaccinated. Then women who are planning to become pregnant, they are also supposed to get vaccinated. Even the 20,000 gold guidelines suggest that all patients with COPD, they recommend all these vaccines in them. They suggest that they should be vaccinated against Tdap, as well as they should be vaccinated against this shingles vaccine, apart from the pneumococcal and the influenza, which they recommend that they should be vaccinated for. So that's all I wish to say from my side. Thank you.
Thank you, ma'am.